So good afternoon. I'm very happy to have this opportunity to talk to you about this topic. When you look at those three words, depression, anxiety, and opioid use disorders, we obviously in our clinical life see overlaps of those symptoms or co-occurrence of those symptoms frequently. And you'd think there'd be a ton of data on exactly how to make diagnoses and how to treat. But really, there are relatively few clinical pearls and a few studies with actual data in clinical populations. I don't know if I'm in control of the slides or not, but next slide. Next one. So because this learning session is aimed at clinicians who are dealing with patients who are misusing opioid substances, we'll focus on the prevalence of mood and anxiety disorders in subjects with opioid disorders and how that changes treatment and treatment outcome. So we'll look at epidemiology, how to diagnose, tips about diagnosing comorbid mood and anxiety disorders as opposed to substance-induced disorders, and discuss available evidence about treatment, and somewhere the word outcomes left the slide. But so NESARC, National Comorbidity Study, and the ECA studies all have looked at and gotten odds ratios of the association between alcohol and or drug dependence and other disorders. And the takeaways when you look at this slide is that the people with drug disorders, which include opioids in these big surveys, actually have markedly higher odds ratios or likelihoods of having major depression, dysthymia, bipolar, panic, and social phobia. And the big differences are in panic and bipolar, actually. So that's important to notice. Also notice these are the associations between disorders. And I'm going to say this point several times along the way. The critical effect on treatment response and outcomes in people with opioid disorders is whether or not they have a depressive disorder meeting the full criteria for disorder or a anxiety disorder at the time they're being treated for their opioid disorder. Old disorders and just high scores on symptom checklists that don't meet disorders don't actually have a significant effect on outcome as far as we can tell. So it's important to be a little bit obsessive about diagnosing the disorder. Unfortunately, it's also hard to be obsessive in many of the clinical situations we're in when you're starting to treat an opioid disorder. So next slide. So here's the conclusions. First of all, if you looked at those odds ratios, you'd find that comorbidity is the rule. I think the other way I like to think about that is when Vermont set up their hub and spoke model for treating people with opioid disorders, they thought people in primary care clinics scattered around the state would actually take care of the large bulk of their opioid disorders. And what turned out to happen, and then the others would be referred to the hubs that would have more different types of therapies for more complex straight patients. And what they found is about 50% of their patients got referred to the hubs, which wasn't the ratio they were looking for. And and a lot of that was because of the comorbidity issues. Like I said, the Association of Mental Health Disorders is stronger with drug use disorders than with alcohol use. The associations for the depressive disorders are actually overall, if you look at the individual studies, smaller than for the other disorders. So what Ed Nunes, who's sort of the godfather of comorbidity and always writes the chapter in the ASAM book on treatment of addictions, he says, when you see depression in an addict, think about actually it as smoke where there might be a fire. Think about anxiety disorders, bipolar, and PTSD as emerging, as they may well have more specific treatments for them, as opposed to some global approach to depression. And also, if it's depressive symptoms and not a full disorder, it's very likely that the depressive symptoms will get better just with the buprenorphine or the methadone, for example, but much less likely if they have a full-blown disorder. So this is a couple, just to show you, I looked at our articles. Here's an article from way back in 1982 from Rounsaville, a very famous researcher back then, where they looked at diagnosis and symptoms of depression in opiate addicts. And what they found was that at the outset of treatment, 17% of them had a full-blown major depression, 60% of the subjects had a mildly elevated depressive symptoms. At 6 months, there was a substantial improvement, with major depression dropping to 12% and elevated symptoms dropping to 31%. And what they said was starting treatment during a major or minor depressive episode, but one which met criteria, was predictive of poor outcome, both in illicit drug use and psychological symptoms, actually less so in functional symptoms like work or things like that, interestingly enough. Now, the other thing that's important to notice here is a lot of the data that we've gotten over the years and still get looked at, you look at if you put depressive disorders and opioid use disorders into PubMed, comes from methadone clinics in the 80s and 90s and early 2000s. One of the things that worries me is the population of opioid use disorders have changed dramatically from a more urban group to a more rural group, from a more diverse group to a much more white group, to there's all sorts of differences that have happened in that time. So I worry about looking at these old studies, even though they still pop to the top fairly quickly. Next slide. More data, this one from 97, also a little closer, but found interestingly that in assessments 1 month after admission, they were at a 16% rate for major depression. So two large studies got 16 and 17% for major depressive disorder. Antisocial was also high in this group. But again, this was a methadone clinic group. Next slide. So prognostic implications. What I told you already is that major depression is associated with greater overall severity of addiction and worse addiction and other outcomes, but only when the subject or patient has a full-blown disorder meeting DSM criteria. Now, they haven't done it with DSM-5 yet, and they haven't done it in this current population. But scoring high on a rating scale for depression without meeting criteria is not associated with worse outcome. So you actually have to be careful about applying diagnostic criteria. We don't know whether that's the case for anxiety disorders, which are much less studied overall. And one of the problems mentioned is, as we get into comorbidity, is the high rates of polypharmacy we get into fairly rapidly. And if you really don't have a full disorder, both anxiety and depression get better fairly regularly with simply treating the opioid use disorder. So diagnose carefully, treat carefully. Next slide, please. So this is in every book or chapter you've ever read about this. To make these diagnoses, well, you have to take longitudinal histories of both the anxiety or depressive disorders and all the substance use disorders that are or have been active in the patient's life. And you need a reliable corroborative historian, often not achievable. It shouldn't stop you from trying, but in a population with many disrupted families, and also, frankly, corroborative historians who are pretty opinionated. Recently, I had two family members in a clinic meeting with my patient, and I got into a terrible situation where one of the family members says every problem in his life has always been related to the drugs, and the other one saying he's not really an addict, he just is depressed. He's always been depressed. And I think the patient and I both left ambivalent about treatment. So it's hard to achieve that level of sophistication in diagnosis. Next slide. In terms of treatment, there actually is a review and meta-analysis from 2017 where they looked at the management of mood and anxiety disorders in patients receiving opioid agonist therapy. There were 22 randomized controlled trials, but only 8 were really of high quality. Nonetheless, they reviewed all of them. So 7 studies actually started antidepressants well after the person was on methadone or buprenorphine. 2 studies showed a significant, statistically significant positive effect of imipramine or doxepin over placebo for symptoms of depression. 7 studies started antidepressants close in time to the start of the methadone or buprenorphine. 2 studies reported a statistically significant positive effect of doxepin over placebo. Now, just to jump in there, the other studies in both these sets of studies, whether they started them after methadone started for a while, or especially the ones where they looked at changes in depression when the study started at the start of the methadone or buprenorphine, the placebo group got better very quickly. So it was pretty hard to show statistically significant benefit on top of that by the drug treatment. But interestingly, you don't see any SSRIs. They've been studied to some degree, mostly sertraline. There hasn't ever been a positive study with an SSRI in addition to methadone or buprenorphine for depression. So there's a total, at least till 2017, there's a total of 4 studies, all with tricyclics. Now, here's the bad news about those doxepin and imipramine studies. They all had more dropout in the active drug group than in the, as you might expect, than in the placebo group. So, next slide. I already mentioned this about SSRIs not looking good. There were 3 RCTs, randomized controlled trials, that just controlled buprenorphine with methadone for effects on mood. There was only one that showed a significant difference. Buprenorphine beat methadone, but for some reason in this study, and I found it hard to figure out what they were getting at, they were both paired with carbamazepine or Tegretol, which seemed like a very odd choice. But only in that setting was buprenorphine better, but that remains to be obviously an open question. Hardly any studies done. Next slide. The most positive thing that we find is psychotherapies. There have been 4 randomized studies of various psychotherapies and 2 small pilot studies where they looked at the effect of depression in methadone-treated patients. 2 of those studies used I don't know why 2 showed up there twice. 2 of the studies of depression in methadone-treated mothers and their infants used relational psychotherapy mothers group protocol, and both had positive results for depression symptoms. There's been an RCT of behavioral therapy for depression. That was negative, but an RCT of acceptance and commitment therapy in patients on methadone, so showed positive results for depression, but no significant results for anxiety. And finally, a small RCT of cognitive behavioral therapy for depression versus non-directive groups showed positive results for both depression and anxiety disorders in methadone-treated patients. Next slide. So, in conclusion, comorbid depressive disorders, as opposed to symptoms only, are associated with worse outcomes in subjects with opioid use disorder. So, we still need to try harder. We need to do careful interviewing of subject and corroborative historian to effectively diagnose. Few treatment studies exist. Psychotherapy studies certainly are the most consistently beneficial approach to depression in patients with opioid disorders. We know practically nothing about anxiety disorders. Tricyclics are more effective but have far more side effects than SSRIs, which have yet to have a positive impact in early studies. There have been no studies with serotonin norepinephrine reuptake inhibitors like venlafaxine or duloxetine, and there are no studies with atypical antipsychotics at this point. Finally, it's too early to say whether buprenorphine or methadone is better, or they're the same on depression or anxiety. So far more and larger studies are needed. And that concludes this talk. We're just up against the end, but if you have questions, there's probably one or two.
Any questions from those calling in? No. And the one thing I wondered about, something that's gotten to be much more on people's radar when it comes to methadone is prolongation,
Yeah.
which is also an issue with TCAs. And don't know if maybe, is that something where you feel like people are really shying away from those because of that?
Well, it's also a problem with SSRIs.
Well,
So,
I think it's more dramatic TCAs, though, is it not? Or am I?
Well, the weird thing about the SSRI data, I think it is longer in TCAs, but it's pretty long in citalopram. The interesting thing in citalopram alone, in the citalopram review of citalopram treated patients in the VA, they never found a single person who went into suicide point or died. When they switched everybody from citalopram to lower doses or to other drugs, the suicide rate in those patients went up. So responding to the new recommendations about citalopram killed veterans.
Wow.
So I don't know what to say. Clearly methadone, that level of QT causes trouble. And the interaction has got to be different than, but so there's another reason in favor of psychotherapy, which probably doesn't increase your QT interval. But one of the great parts about having people on bup or methadone is they have to come off enough that you might convince them to stay for a psychotherapy session related to their anxiety or depression. So that's.
Yeah, I actually have one guy who he's tried to get off Suboxone on a number of occasions, and every time he gets below 3 or 2 milligrams, he gets depressed enough that he ends up hospitalized for severe depression.
Mm-hmm.
So it's just there seems to be, and there have been some studies looking at the mechanism in terms of the antidepressant effects of buprenorphine as a molecule itself.
Yeah.
So
and there's those studies showing that a low dose of buprenorphine as an augmenting agent in depressed people without an opioid disorder get better.
Yeah.
And these studies are amazingly positive. well, have an amazing effect size in relatively small studies. Somebody must be studying it
Yeah.
because the buprenorphine people could get another patent.
Yeah.
I hate to be so cynical. I'm sure they're doing it for the good of the patient.